Welcome to our community of practice, our Choosing Wisely Resource Stewardship webinar in pediatrics. This is our first meeting together in 2022. So great to see so many of you who've been able to join us. We know it's certainly still a very busy time for those in Ontario. We're just in another wave. I'm losing count of which one it is, but certainly faced with a lot of staffing shortages that might impact our presence from many Ontario physicians today. But we're delighted to see some names. We have membership throughout from east to west along Canada, and we are delighted for those of you who are able to join us today. So welcome all. And go ahead and we'll get started. So I think we're going to start with a couple reminders. I think everyone is pretty used to virtual webinars at this point, but just as a reminder, always to just try to have yourself on mute if possible while others are presenting. We have 3 different groups presenting with us today. As always, we really value everyone's input. And so we are going to have a Q&A towards the end. But throughout, as you have questions, please feel free to put them in the chat, and then I will get to them at the end as I moderate the question and answer session for our groups. So please just put your questions in as you have them, or if you want to save them to the end, we certainly always as well welcome you to unmute yourself and feel free to speak up. This is really, as always, an opportunity to share ideas and learn from each other. So we know that the interactivity certainly is a big part of that. Next slide, please. So our agenda for today, I just have a couple more slides of introductory material, and then we'll go ahead and get going with our 3 presentations. Our theme for this webinar and this practice is really around respiratory infections, which I was hoping that we would be saying that we're emerging from, and as we typically are starting to see in April, but I feel like we are still very much in the midst of a lot of respiratory infections, just knowing that we're seeing a lot of COVID cases again. But we have 2 presentations related to bronchiolitis. So we're being joined by our BC Children's Group, Drs. Claire Seaton and Dr. Dylan Ehman, who will be presenting on some bronchiolitis work related to the VIP network, as well as then we're moving back to Ontario with our Sick Kids group. We have a group of outstanding fellows, Dr. Marie-Pier Lirette, Dr. Larissa Shapka, and Dr. Maria Jose Conejero Muller. I know I'm going to butcher that, and she's gonna make sure I pronounce it correctly by the time she leaves Sick Kids. And then our third group is Drs. Tim Lynch and Dr. Seppi Tahari, and they're going to be talking about the use of chest X-ray in the diagnosis of pneumonia in children. As a reminder, the community of practice, we'll just go to the next slide, is really an opportunity to foster knowledge sharing and collaboration and learning around those who are interested in high quality value added care by really focusing on overutilizations of tests and treatments. And we do this through a number of ways, through by building capacity and quality improvement and resource stewardship, by sharing lessons learned and successful initiatives related to resource stewardship, around supporting continuous quality improvement and resource stewardship efforts, promoting consistency in recommendations around best practice guidelines locally, provincially, nationally, and even today is giving you a flavor for international presence, as we're going to hear about some North American experiences, around supporting spread of evidence-based practices, developing a central repository for idea sharing, and engaging in new opportunities for collaboration. We really, really hope that this network that we have started over the last few years will continue to grow, again, have that presence from coast to coast in Canada for all who are really looking to move the dial when it comes to resource stewardship. And I'll just share with you just a quick Pearl or what I was reading recently. So every year, Paediatrics, the journal, comes out with the top overuse of items related to children. The year before, I think it was published in January of this year, for those of you who haven't seen it, and went through some nice items. And I like it because it talks about different areas of overuse and care related to inpatient, outpatient, community, academic. It really has something that is applicable to everything on their list. But what they talk about is sort of what the natural experiment that the pandemic has had in some ways. And I always like to look for those silver linings over the last couple of years. And really the pandemic has been a natural experiment they talk about for de-implementation. So a lot of care has been put on hold or delayed. And we certainly know that that in some circumstances has led to adverse outcomes and to delayed diagnoses and some poor outcomes for children. On the same regard, some of these delays or holds or pauses in care, or even stopping in care, has actually been a natural experiment in maybe in reducing some tests and treatments that probably never added value and never added care. And so really an opportunity to sort of reflect or, you know, reset the dial, so to speak, on looking at the care and practices that are needed and not restarting some of those practices that really were never needed at baseline. So just a really great way to, you know, try to look at some of the silver linings and really the opportunities here. And I think the pandemic has really brought the call for resource stewardship work and advocacy towards this work at a forefront as we really look at the impact that it's had on the healthcare system and has really had on children as a whole. Next slide. As a reminder, we have partnered with Children's Healthcare Canada as our hub. So for all of our prior webinars, recordings, information, again, opportunities to connect individuals from this group, please check out our Squarespace on the Children's Healthcare Canada website. And next slide. Lastly, just going to also remind you that the Choosing Wisely Canada National Meeting is coming up in May. For those who are interested, it's free, which is why I felt very comfortable, you know, sharing that and advertising it here. For those who are interested, you know, if you don't have time to attend both days, it's a virtual meeting, so much easier for those to attend. Again, a great opportunity to collaborate, to network, to learn from each other, of others who are interested in this space. And I think if that is it, yeah, so I'm going to go ahead and hand it over to our first presenter from BC Children's out in British Columbia, Dr. Ehman and Dr. Seaton. Thank you for joining us today.
Thank you very much, and thank you for the opportunity to be able to talk about our project here. So we're going to talk a little bit about our experience as part of a multi-institutional project kind of overseen by the American Academy of Pediatrics called HI-FLO interventions to facilitate less overuse in bronchiolitis, a bit of a mouthful. And I believe our sick kids colleagues will be familiar with this as the two sites in Canada. Next slide, please. So I'm not going to go too much into the actual bronchiolitis portion, but mostly focus on our experience in kind of working on this project here. So, but just overall, the rationale is that HI-FLO in bronchiolitis is increasing, and that the data for its use in bronchiolitis has only recently there have been evidence-based data to use it. And in fact, it's increasing so much that we found doing this project that at Children's, at least in the 2019-2020 respiratory season, half of our bronchiolitic patients in uncomplicated bronchiolitis were put on HI-FLO during their admission at some point, which was a higher number than we thought we expected before actually looking at it. So in terms of the data itself, advance forward 2, please. And again, yeah. So the recent meta-analysis show that HI-FLO is useful as a rescue therapy. So it can prevent escalation to positive pressure ventilation for those who need more support beyond conventional therapies with low flow. But not as if you start someone on HI-FLO, there doesn't seem to be a benefit in terms of overall disease modification versus low flow. Next animation, please. We see no difference when comparing starting on HI-FLO versus starting on low flow and then advancing if needed in duration of respiratory support, utilization of the ICU, intubation, or overall length of stay. Next animation, please. And finally, we see at 24 hours, you see no change in heart rate, rest rate, or comfort scores. Because I know we anecdotally see that these children do have clinical improvement when we put it on. And there might be some short-term improvement in rest rate, but the evidence shows that 24 hours at least, there doesn't seem to be a significant difference. Next slide, please. So efficient use of this tool is important. It's a limited resource. There's only a certain number of machines at each center. It does increase the healthcare use. It's more expensive. The equipment costs more. It requires specialized training, and then typically it requires respiratory therapy support as opposed to low flow, which often doesn't need that. We're not good at coming off high flow. So once they're on, they kind of have a longer duration, perhaps longer than they might need. And then finally, in the age of COVID, it's considered an aerosolized medical procedure. So sometimes more PPE is needed. And just to touch back to the delayed weaning, and also some smaller centers can't or don't have the policy to monitor it. So it would require transfer to higher levels of care and all the complication that requires. So based on this, our center developed a guideline on the initiation, use, and weaning of high flow in uncomplicated bronchiolitis and implemented it in August 2021. And it's actually available for anyone to see. So if you want to look at our kind of guideline site, that's there. And the point was that we defined like when it should be started and who would benefit, and then to optimize what to do prior to starting it to make sure that it's really being used in an effective way. And then once this guideline was created, we had planned to do a QI project to actually look at the effects of the guideline, how effective it was, and what differences we actually saw. Next slide, please. And so that's kind of where this project comes in. And right around the same time, the AAP had a project through their QI network called the Value in Inpatient Pediatrics Network for a project that was to do basically the same thing that we were looking at in terms of evaluating our guideline. And so it's called HI-FLO. And next animation, please. And so they announced two kind of arms. One question was to answer if the proportion of bronchiolitis patients started on high flow could be reduced by using like a standardized initiation pathway that focused on like akin to a surgical pause, really making sure that you're optimizing supportive care prior to escalation. And then there was a separate wing talking about improving weaning from high flow. So our new guideline kind of already incorporated the first arm, and so we felt that it would be a good idea to join this project to kind of collaborate, to kind of work on look at this guideline as we were already planning on doing. Next slide, please. So, for those who have not been familiar with multi-institutional projects like this, we just kind of want to overview kind of what we were given as part of this. So once we joined, the AAP provided a number of materials, and so they gave us a timeline, kind of when we expect certain things should be done. They talked a little bit about approval for a research or QI project. The AAP had already approved the project through their own internal IRB, and we found that we did actually not need IRB approval as it was considered a QA project, and the intervention or the guideline was already standard of care, so that we weren't actually testing anything on people. They gave us specific, outlined a rationale, aims, methodology, and specific criteria for patient selection, as well as recommendations for data collection. Now, unfortunately, as it was primarily an American study, a lot of the data collection recommendations were through various EMRs and Epic searches, that sort of thing, that didn't apply to us. And we'll talk a little bit later about some of the challenges we faced in that regard. And finally, they gave us some information dissemination materials, and then we're available for consultation and support. So we had regular kind of webinars, some coaching calls with peer mentors, and again, availability through email or contact for other issues. Although our challenges were mostly site dependent, so the ability of getting support for some of the stuff from the American side was limited, but it was there if we needed it for more of our methodology. Next slide, please. So these were the aims as provided by the AAP, and this is kind of based on some pilot projects they had done at individual centers in the States. But basically, as I said, to reduce the proportion of infants with bronchiolitis by 30%, reduce the total hours of treatment with high flow by 30%, and as a process measure to ensure that, or see if at least 80% of the patients started on high flow, would have this pause and optimize support. And so in our study, it was that they are appropriately started as per our guidelines. And finally, as balancing measures to ensure there weren't other unforeseen kind of complications, we also monitored the length of stay in the emergency department and length of stay inpatient. Next slide, please. So as I said, the guideline was already implemented. So our intervention for this project was mostly to raise awareness of the guideline. It kind of was released without much fanfare. And so, when we started this, not many people actually knew it existed. And so our work was cut out for us to try and get practitioners as well as allied health on board. Some examples here kind of showing the things that we did, but basically we early on kind of liaised with the respiratory therapy leadership, and they were also in agreement with this project and engaged. And so we were able to use them very intensely in terms of being available for consultation and kind of promoting the guideline when starting HI-FLO, because at least at our center, HI-FLO is started by RTs, so they're always as part of the process. We emailed practitioners, we set up websites with some infographics, as you can see there, and then put displays. Another picture there is an example of a whiteboard. We participate in academic rounds talking about the project. We presented to nursing staff. And additionally, kind of more than just our site, we did do some seminars in terms of HI-FLO and bronchiolitis on a province-wide basis, which is especially relevant, not necessarily for this guideline kind of test, but it turns out that a lot of our patients come into the hospital transferred on HI-FLO. So we'll talk a bit about that more in a sec. Next slide, please. So, this is a detailed slide. I'm not going to go in detail, but this is kind of what they provided in terms of the data that they required, as well as their recommended inclusion and exclusion criteria. So the data was not too onerous to collect, and actually most of it could be done through our provincial health authority data collection systems already, and only the data about the HI-FLO needed a chart review. And then, as you can see there, they gave inclusion criteria and exclusion criteria that were quite specific, but overall, comparing the respiratory seasons in 2019, 2020 versus 2021 and 2022, kind of skipping the no RSV season of COVID, and being aged 1 month to 2 years, and then basically patients that didn't have complications, so that were otherwise healthy. So the most difficult part for us was the data collection, and so like I said, the EMR queries were not applicable to us, and so we did have to reach out to the provincial health authority for kind of admission data. And then once we got that, after a bit of a delay, we were able to then do a chart review and get some details in terms of our baseline on how long they're on a HI-FLO, who was it start on a HI-FLO, etc. Next animation, please. We also worked with respiratory therapy so that the RTs actually collected clinical data at the bedside. So when they were starting HI-FLO, they kind of were able to record their clinical status, whether they had what sort of supportive measures they had done prior to starting, and what the effect was. So that was very valuable to have that. Another issue is that we switched EMRs halfway through the intervention period, which wasn't under our control, unfortunately, which kind of caused a delay in a lot of data collection and in other kind of external services. But having this new EMR will make data collection much easier in the future for future projects. Next slide, please. Some of the challenges that we faced as being part of this project. So, is it research versus QI? And we had, when we tried to talk about people about this project, it was a bit of a back and forth. And so it makes it complicated because do you need IRB approval? Do you need QI ethics approval? Do you need both, which complicates things? We found that we had to work through multiple departments. So Dr. Seaton and I are mostly based on our inpatient clinical teaching unit. So that was pretty straightforward. However, we also found that the almost all but one in terms of our baseline period of patients started on a HI-FLO were actually started in the emergency room, most under the care of emergency docs. So we really wanted to get them on board, and that required a process and working through those channels. And so having multiple departments kind of complicates things. And finally, I talked a little bit about our data collection issues, but there was a long delay to get the provincial data. And before we switched our EMRs, it was all paper charting, so that also complicated things to try and track it down and do paper chart reviews. And then the converting to the new EMR will improve data collection, but it meant that they're for a long time and still ongoing. Ancillary services are much more focused on that conversion as opposed to being able to provide assistance in terms of data collection and analysis. Next slide, please. Just quickly going over our, you can advance through this 3 clicks. So we had in our baseline period, we had 100 admissions that met the date and age criteria. 26 were excluded based on the complications or being transferred in. And so that left with 74 total admissions. And we found in our period, half of them were started on high flow and half were not. And of those 37, 36 were started on high flow in the emergency department. So like I said, the interventions to prevent high flow start really revolved around the emergency room. Next slide, please. This slide just talks a little bit about the demographics of our baseline, but suffice to say that they were about equal in terms of, we couldn't see any obvious difference in these variables in terms of who was started on high flow and who wasn't. And the length of stay, both in the emergent and on the ward, kind of overlapped with each other, which is consistent with what the data shows, that there isn't a significant difference in length of stay by being on high flow. Next slide, please. And again, these are kind of the week QIDA cycles of our project. And so they're each, unfortunately, with our single site, it's quite noisy data because on average, there's about 9 patients per cycle. And so as you can see kind of on the right half of the graph, when you have maybe 1 or 2 patients with an abnormally long stay or a long treatment, it kind of can set the whole graph off. Now we can't show the AAP preliminary data, but all our numbers are somewhat consistent there, but much more smooth and less noisy, which is the advantage of being in a multi-site, contributing to a multi-site group and having much higher numbers in the 10,000 as opposed to 770. And so other than this, all our numbers seem to consistent with other centers, except for our ED length of stay seem to be about 2 hours longer than the average for every other center. Next slide, please. And so in terms of the intervention period, which is kind of just finished data collection, unfortunately, we have to, again, because the way our EMR works, we have to wait for the Provincial Health Authority to give the total admission data. And so we're waiting on that for reconciliation. So we don't have anything to share with you yet in terms of outcomes. But some of the preliminary data that we've collected as we go shows that there was 35 starts recorded, which is 2 less than the previous season. It was considered in about 2/3 of the applicable starts. And interestingly, more than 1/3 of the patients who were on high flow arrived already on high flow as part of transport, as were the tertiary center. So, in terms of benefit of reassessing our high flow initiation, that's limited when only 2/3 of the patients you have in your hospital on high flow were actually started here. So to consider in the future, working on the weaning and the maintenance of the high flow. Next slide, please. And this is our last slide. So, in summary, working with the AAP project has given us the opportunity to contribute to a large, large project and answering questions that have high numbers of patients. Because with only 70 patients per year, our ability to get definitive results that are statistically significant is somewhat limited. They've done a lot of the planning and they give you a lot of materials, which is very convenient. However, it's sometimes hard to fit a project that's meant to be generic to multiple sites to your own specific site. We can't give you any conclusions yet as we're waiting the full intervention data. But and like I said, the future, we plan to implement the other arm and hopefully work on our weaning of high flow, especially considering a lot of them come from the outside. So, the issues with the big project in a small site is to make sure that it coincides with your individual institutional review boards, make sure that you're on board with the various research committees for each area, and that your EMR is compatible and makes it easy to get the data. And also we found that, the AAP recommends data collection based on kind of US standards and practices, and Canada and the US have slightly different data collection laws and policies. So that was a bit of an issue as well. And then we noticed that this year, or we have noted that there is a bit of an abnormal RSV year this year. So that may confound our results somewhat in terms of any changes this year versus 2 years ago, whether it's due to the skyline or due to the fact that it had a bit of an early start to the RSV season. And with all the COVID stuff in place, may have changed things. And that's it. Thank you very much.
Great. Thank you so much, Dr. Ehman. It's great to hear your experience in BC and just think at the Sick Kids experience, which we're going to move to now to hear about their experience with this project with the VIP network and some different and similar reflections and experiences.
Hello everyone. So this is the SickKids team. My name is Dr. Maria Conejero, and I'm here with my colleagues to talk about bronchiolitis. Less is more, our experience implementing non-evidence-based interventions at SickKids. As Dr. Ehman already introduced, this was also part of this VIP value in inpatient pediatrics network that is supported by the AAP work. Next slide. So the objectives of our presentation are to describe our KI initiative to reduce heated high flow and non-evidence-based interventions in bronchiolitis, and to discuss our successes and challenges, including our experience participating in this North American study, and also share our lessons. Next, please. Thank you. Okay, so similar to what Dr. Ehman already spoke, this QI initiative started as part of the VIP HI-FLO project, which the main objective was to reduce the overutilization of heated high flow by 30%. And how were we going to do this? By implementing this pause before starting heated high flow. We also wanted to reduce non-evidence-based interventions at our site. And we wanted to do this by standardizing bronchiolitis care, reducing unnecessary interventions by 50%. And how we do this was by creating care efficiencies that were specific to the work we do at SickKids. Next slide, please. So this is a little bit of how we did our journey. So we did all these steps, and we had in our background the support of this VIP network that, as Dr. Ehman already shared, was composed about webinars, small group coaching, and education that was very useful for us. And we're going to go into detail to all of these steps. Next. So the first step was creating a multidisciplinary team, and this team was conformed by people from the emergency department and from the inpatient ward. It was composed by doctors, staff, and fellows and residents from the ED and the inpatient world, nurses from both sides, and also for the important support of RTs. Next slide. This is how our baseline was. This was the last normal bronchiolitis season before our COVID started, so from 2019 to 2020. As we can see, the median of patients that were admitted and that were started on bronchiolitis for our site was around 43%. And we have here in green that the goal that was proposed by the VIP study was to reduce that to 30%. Next slide. As we said, we also had an objective of reducing the non-evidence-based interventions that we did in the bronchiolitis care. And we reviewed our baseline data, and we saw that we, with the two main interventions that we did that were non-evidence-based for bronchiolitis care were bronchodilators and x-rays. And if we added these two interventions, that was 70%. Those were the 70% of the non-evidence-based interventions that were applied in our care of bronchiolitis patients. Next.
So in terms of next steps, then we developed our measures, and as it was already mentioned, in QI, we've got outcome, process, and balancing measures, as you all probably know. So we had two different goals. So for the reducing heated high flow, our outcome measure was the percentage of patients started on heated high flow out of all the ones admitted for bronchiolitis. And for reducing non-evidence-based intervention was the percentage of non-evidence-based interventions that was ordered or performed in the children that were seen for bronchiolitis. In terms of our process measures, for the reducing heated high flow was the percentage of patients that received the HIP, so the pause that we described earlier. And in terms of the process for the evidence-based interventions was the percentage of order SIP that was used. And again, similar to the BC group, our balancing measures were the length of stay. Next slide. So as a group, we developed this initiation workflow. Unfortunately, we weren't as lucky to have already had this in place, so we had to do this at the start of the project. But basically, it kind of takes you through for frontline providers what to do with a patient with bronchiolitis. So for those that had moderate to severe bronchiolitis and that you thought maybe would need heated high flow, we then asked the team to assess and then document using the bronchiolitis severity score, which I'll go into more detail in the next slide. And then at any point, if there was any respiratory support that was needed immediately, then obviously the pathway didn't apply and you would consult RT, ICU, etc. as needed. However, if the patient didn't need it immediately, we then asked the providers to complete the HIP, so the pause, which we call the bronchiolitis bundle at Sick Kids. And that consisted of mainly things that we probably all do already, but this time it almost felt more like providers were actually doing something for the child. So things from antipyretics to assessing hydration, suctioning and applying oxygen, and really to just optimize their comfort. After about 30 minutes, the team would reassess again and re-score the infant, and then decide as a team whether the infant had passed, therefore just continue with observation, or had failed, i.e. had worsened, and then at that point you'd consider heated high flow and consulting RT. Next slide. So one of the things that we also implemented was this bronchiolitis severity score. And there was a lot of debate within our group whether we should be using this or not. The VIP study actually didn't recommend one particular. They said it was up to the site if they wanted to use one. And at Sick Kids before, we didn't have a score. We have to remember that none of the scores have been validated in the literature. So this was kind of like the drawback behind not using one. However, we felt as a group that the benefits of having a common language to speak between the inpatient and the emerge, between the nurses and the RT and the doctors was really quite great. And we felt that having an objective measurement of something that can be quite subjective when you describe an infant with worker breathing, for instance, we felt that that would be quite valuable. So we decided to go ahead with this one that's shown on the right, which has been shown in the literature to have good inter-observer agreement, but as I said, is not yet being validated. Next slide, sorry. Other interventions that we did was we updated our hospital-wide bronchiolitis policy, and we implemented lots and lots of IT changes. And one of the lucky things at our center was that we did have EPIC, which helped with some of the VIP things they were requesting from us, but things that we implemented was an order set for the inpatient and emerge, documentation templates, charting for the nurses for the score. We integrated the score into the IT system, so lots of changes there. And we provided a lot of education to nurses, RT, doctors, and that was very well attended and received. Next slide, please. So these are our results. So as you remember, our first goal was to reduce the heated high flow initiation by about 30%. And so here on the y-axis is the percentage of those started on heated high flow out of those admitted for bronchiolitis. And on the x-axis is all the various cycles, with implementation being cycle 9. So you can see the line in red is all the centers through the VIP study, and the line in blue is the one at Sick Kids. So you can see that it's kind of all over the place, and the benefit of having multiple centers together makes it a little bit cleaner. And you can see after implementation, maybe we kind of went down on our numbers, but you see cycle 12, 13, 14, 15 onwards. We have no admitted patients for bronchiolitis. No one starts on heated high flow. So really we weren't able to kind of tell if our implementation worked or not. Next slide, please. Our other goal was to reduce non-evidence-based interventions, and as Maria presented, our two main ones were bronchodilators and chest x-rays. So we focused on those. And bronchodilators, we focused on those less than 12 months because there's a bit more gray zone whether we should do a trial of them in the 1 to 2 years old. So you can see here that after implementation, our numbers maybe started to go down a little bit, but then went back up again. So probably we didn't make any changes, or it's hard to tell given our low numbers. Next slide, please. In terms of chest x-ray, again, this is for up to 2 years of age, and you can see here that probably we didn't really make any difference after implementation. Next slide, please.
Okay, so now we'll move on to talking about what worked and some of our successes. So one of the biggest successes that we had was that we were really able to develop a common bronchiolitis language that was used both within different areas of our institution as well as across our institution by having the order sets, the bronchiolitis score, and the high flow initiation pathway. We really also tried to focus on initiation when we, on education when we were rolling this out. And in addition to our planned strategies and sessions, we were also very fortunate to have a really strong interdisciplinary team who championed this in real time in their respective work environments. So for example, we had emergency department nursing who provided kind of multiple just-in-time education sessions and also encouraged their colleagues to score all patients with bronchiolitis, even if they wouldn't be eligible to kind of enroll down the pathway if they just had very kind of mild work of breathing or symptoms, just to promote familiarity with this and kind of did that development of a common language. And RT for their department also kind of developed a reference card to carry around on their lanyards. So there was a lot of kind of buy-in and a lot of really creative thinking in terms of trying to promote this initiative on the ground level as well. We also wanted to take a moment to highlight how we felt that some of our successes related to our participation in a VIP or US-based stewardship work. And I know that the BC group has touched on this a little bit, but we wanted to share our experiences with that as well. So for us, I think one of the biggest benefits of being connected with such a large and kind of well-established network was access to resources that we wouldn't otherwise have access to for this specific initiative. So there were the promotional and educational materials, including a bronchiolitis booster series, videos and modules that were kind of accessible to all those engaged in patient care and targeted at all professions. And there were also some very practical kind of quote unquote just-in-time videos. They were about 3 minutes long and to support kind of real-time patient care decisions, which we received very positive feedback on from a number of individuals who were accessing that to kind of try to boost their knowledge and help in their decision-making. And having the support of coaching calls and webinars through the VIP network was also very helpful. It provided not only an opportunity kind of for expert direction, but it was also really interesting to hear the challenges and successes of other sites, to exchange ideas and to reflect on how we compared to the other hospitals in a large network. Next slide, please. So one of the biggest challenges was the low number of bronchiolitis admissions, which certainly seemed to occur at sites across the network and wasn't limited to sick kids, but it did limit some of the momentum that we could build in terms of our bronchiolitis initiatives. We found that our HI-FLO initiation pause was often either not done or not documented despite kind of all of the educational and promotional kind of initiatives that we were implementing, and certainly having less volume of bronchiolitis and kind of then less familiarity because of lower volume may have contributed to this. And as the BC site highlighted, similarly for us in Toronto, the majority of our patients with HI-FLO actually had already been started on it before they were transferred into sick kids. And so they were excluded from the pathway, which also may have contributed to some confusion kind of on the front line about what score should be done when and who should be kind of enrolled in the pathway. There also seemed to be a variability in the familiarity with the pathway in the emergency department versus the inpatient setting. Also could potentially be related to how frequently HI-FLO is started in each of those settings for bronchiolitis, which is something that we're hoping to explore more for next bronchiolitis season and target specifically. And of course, there's always competing priorities in busy hospital settings, and COVID certainly added a layer of complexity in trying to navigate projects as well. Next slide, please. So as you can see on this slide, there certainly was a lot that we learned this year about trying to change practice and achieve sustained improvement. I think one of the takeaways for us was really to consider how things are interrelated kind of early on in the project planning. So it might sound basic, but when we started to think about the scope of the project, we realized that if we were investing our efforts into the heated HI-FLO for bronchiolitis already as part of the VIP network, and that it also really made sense to explore all of our other bronchiolitis interventions and improvement opportunities as well, as they were all impacted by our interventions with the bronchiolitis bundle. And so overall, our main takeaway was that even though this was a season with low numbers for bronchiolitis, we were still able to develop a shared language to approach bronchiolitis. And we built some momentum and laid the groundwork to continue to work on de-implementing unnecessary interventions in future bronchiolitis seasons, and are considering kind of some next steps, including exploring whether there could be a possible HI-FLO wean arm for the inpatient setting as well. Next slide, please. So in terms of proposed recommendations, I know there's certainly already some choosing wisely recommendations around bronchiolitis, but if we were to think about some of the takeaways from our work on this project, they would be not to implement HI-FLO in mild to moderate bronchiolitis without first optimizing supportive care strategies. And then the other recommendation would be not to routinely administer bronchodilators or perform chest X-ray in mild to moderate bronchiolitis. Next slide. And that brings us to the end of our presentation. So thank you very much for your attention.
Fantastic. Thanks so much to the Sick Kids group. It's certainly not the first time we've heard about bronchiolitis at this webinar, and I have a feeling this is not going to be the last time that we hear about overuse of unnecessary or non-evidence-based treatments in bronchiolitis. So thank you again. I'm now going to hand it over. We're going to shoot over to London Health Sciences, our group there. Thank you to Dr. Lynch and Dr. Tahari for presenting on another respiratory infection related to chest X-rays and pneumonia.
Great, thank you for the introduction and invitation to be here today. So my name's Tim Lynch. Dr. Tahari, I believe, is here as well, but nevertheless, we're quickly going to review some of the issues surrounding radiographs for pneumonia. I've deliberately left point of care ultrasound out of this session, so that's a separate entity probably to be discussed in its own right. But next slide, please. As we all know, pneumonia is a fairly common diagnosis, although during the pandemic, it seems to have almost disappeared to the point where I've actually not seen very much of it for the last 2 years. Worldwide, though, huge morbidity and mortality, less so obviously in our region. And in the context of pneumonia, we're certainly not talking about bronchiolitis or croup asthma. It's that patient that comes in with fever, cough, maybe has some abdominal pain, you hear crackles, might have some tachypnea, low SATs. That's sort of the patient that I'm envisioning in my mind when I think of who we're discussing today. Largely viral causes in young infants, but in the school-aged children, strep, of course, would be at the forefront of etiologies. And radiographs, for the most part, are obtained in a lot of different settings by a lot of different clinicians, depending on their training and their interpretation of the guidelines and things of that nature. Emergency departments are probably the #1 users of chest radiographs, more so than the the clinic or office setting. Next slide, please. So in terms of looking at guidelines that are published, I think it was back in 2011 that the CPS came up with the current statement. I know they've modified it since, and as did the Infectious Disease Society of America. So these were divergent opinions, if you will. The IDSA felt like pneumonia was more of a clinical diagnosis, and that radiographs for straightforward pneumonia were not indicated, where the CPS initially back in 2011 essentially said do an X-ray because you can correlate the etiology of pneumonia based on X-ray findings. Other places we often turn, TREC and CAPE, haven't really weighed in terms of the provision of guidelines for clinicians. Next slide, please. So in terms of imaging specifically, classic teaching in radiology textbooks, Swiss Check, for example, would suggest that 2 views, namely the frontal and lateral view, are indicated for pneumonia. However, there is some cost in that regard. If you look at the additional exposure of a lateral X-ray, it's estimated to be 2 or 3 times that of a frontal view. It does take a little bit longer, especially in the younger children, so there's added expenses, and with more testing and more reviews, often we do find more things and need more therapy. So there's that potential for increased antibiotic use as well. Next slide, please. So currently, different organizations, the World Health Organization, the British Thoracic Society has recommended against the use of lateral chest X-rays routinely. There's various degrees of evidence out there that you can look up and read and try to make your own informed decision. The CPS specifically, as I alluded to, is still suggesting that 2 views are indicated if you elect to pursue radiography. And on the next slide, the wording is actually written. So if you could advance the next slide, please. So there's the verbatim from the current statement, which is essentially saying that a chest radiograph should usually be obtained both views, and then later they sort of slant it, saying that perhaps it's not always essential. So a bit of terminology change, I believe, in this updated statement, but nevertheless supporting the use of 2 views. Next slide, please. So the question, to answer essentially would be, whether a lateral X-ray is required in the, routine examination of a patient with suspected pneumonia. Is a frontal view sufficient? So we'll turn to some of the literature that is out there. Next slide, please. So we'll get there eventually, but prior to that, as I mentioned, the radiation exposure and potential cost may not be a lot to the individual patient, but to the system, it certainly is, given the numbers of X-rays that are being performed in Canada even today. Again, I know that point of care ultrasound is being used in a lot of centers, but X-rays are still, as I say, fairly prominent. Next slide, please. So this is where it gets a little awkward. I'm presenting a study I did, way back when, with a great group of researchers, Serge Gouin, Charles Larson, and Yves Patenaude at the Montreal Children's, and I was there as a fellow. It was an interesting study in that it continued after I left, and then took several years to analyze and eventually publish. But this was a clinical attempt to determine the additional value of the lateral view. So essentially, this was a randomized controlled trial where patients had both frontal and lateral X-rays completed, and then in roughly half of the patients, the lateral view was concealed from the clinicians, so they were interpreting the frontal film alone or both views. And then the gold standard was essentially consensus interpretation by a group of pediatric radiologists who had access to both views. Next slide, please. So in this study, we concluded that the clinicians' interpretations with access to one or both views were essentially the same, and that the addition of the lateral X-ray did not alter the sensitivity or specificity of the pediatric emergency physician in making their diagnosis of pneumonia in children. Next slide, please. Other authors have weighed in on this topic, looking at whether a frontal view is as good as a frontal and a lateral view in diagnosing pneumonia. A lot of these studies, including one that our group did way back when, looked at a lot of the radiographic literature, or sort of looking at radiologists' interpretation of one versus 2 views retrospectively, or even comparing their interpretation of one view to both views in terms of kappa level of agreements and such. So to summarize that literature without getting into too much detail, but it's estimated that approximately 40 additional laterals need to be done to make one additional diagnosis of a pneumonia. So it's sort of a number needed to treat, this is sort of the number needed to diagnose. So the question then to ask is that acceptable or not, based on some of the radiology literature. Next slide, please. So in terms of consideration / recommendation, is a chest radiograph required in children presenting with a clinical diagnosis of uncomplicated pneumonia? Again, that I think to some extent ties into where you practice. And then secondly, not to routinely perform a lateral chest radiograph for uncomplicated pneumonia. So this is something that I think, as I said, I have a bias in this topic based on sharing a study that I was involved with way back when. I think as a clinician now for over 20 years, I can honestly say that a lateral chest radiograph in the setting of suspected pneumonia rarely changes my management or leads to a diagnosis that I did not see in the frontal or did not suspect clinically. So that's one comment. The other dynamic at play is who interprets these radiographs. When do they get interpreted? We know as pediatric emergency physicians that our concordance rate for real-time interpretation of radiographs is very high compared to our radiology interpretation later, and management rarely changes. Chest x-rays a little more variable because they are a little more finicky to interpret, but at the same time, a lot of clinical decisions are made in real time, and we base those on our own interpretations. You could delve through the C-spine literature for trauma patients, looking at the additive value of the trauma oblique films that some centers have done in the past. Our center currently just does the 3-view screen. So there are other similar sort of scenarios in clinical practice that we're trying to minimize the use of radiographs. Next slide, please. So again, the question to be answered further is whether we could potentially liaise with the CPS, the ID committee or acute care committee, the emergency department section, which doesn't really write position statements, but nonetheless, and consider whether a lateral X-ray needs to be, a routine view. It's been a while since I've sampled the country, but where I trained and then where I, as a pediatric resident and as a fellow, one view was kind of the view that was done. We did not do lateral views, 20 years ago when I was in training. So in speaking to our local radiologists, they are not married to the lateral view. In fact, our sort of chief of radiology has told me that he'd be happy to interpret what we order. So again, it's something that potentially has room to be considered here. Yeah, so I see some questions here, the cost saving time. So, I mean, there is, an additional charge to interpret, 2 views from a payment schedule is what the radiologists tell me. And I think when you speak to the technicians, the lateral view is more challenging. Pre-PACS, it definitely needed to be repeated a lot because you had to, sort of dial up the penetration in advance. That's less of an issue now, but it is, as we all know, X-rays in young non-compliant children can be time consuming as well. So there's definitely a time cost for sure. So I will stop there, and I think there's a group session with questions, and would be happy to obviously participate in that. So thank you.
Fantastic. Thank you, Dr. Lynch, and thank you really to all of our presenters today, our 3 groups, really to highlight some opportunities for improved stewardship with some really common respiratory infections that we see in children, albeit certainly impacted by COVID, but certainly still there. I'm going to open it up, as mentioned, for questions. I know one of the questions, actually both of the questions were actually already answered in the chat related to, what type of statistical analysis can you use when it comes to measuring bronchiolitis? And, really the answer is both, but in both of these studies, control charts were used with really just the months of where bronchiolitis is predicted to happen, which I think was one of the challenges this year and really impacted and limited the results. And then also Dr. Lynch just answered the question around time savings with chest x-rays. Are there any further questions, recognizing that we only have a few minutes left? And also feel free to unmute yourself. I can certainly then speak up to Dr. Lynch, just speaking to London's group, and I think it'd be very interesting to, use our group if as interested to sort of sample across the country if as one way to see what are other centers doing if currently with pneumonia diagnosis in children. I could say at Sick Kids, we definitely use a lot of POCUS, but there's huge variability based on training experience and comfort with POCUS. So also chest X-ray and 2-view chest X-ray. I think one of the arguments for the use of chest X-ray and not necessarily 2 views, but at least 1 view is around, the challenge in diagnosing pneumonia in children. And, we often hear crackles, which sometimes are just transmitted upper airway sounds and harder to distinguish. And so sometimes, is a chest X-ray or other imaging modality like POCUS reduce the need for an improved antimicrobial stewardship. But it'd be very interesting to see, how many do you need to treat? I think we've all had those cases of that lateral chest X-ray showing that retrocardiac infiltrate that you didn't necessarily see as well in the AP. But as you said, that's probably very, and I think we all know in practice, very uncommon. And usually 1 view is enough along with your history and exam to help make the diagnosis or not. So I guess the question I would just have, has there been any look at the impact on antibiotic use or reducing or increasing the need for antibiotics? Or, when you also talked about when radiology rereads the films, there's also, a lot of practices will not stop antibiotics if they've already been started, but if radiology calls an infiltrate that wasn't seen, then at least in RED, we call the family and start antibiotics, even though it certainly could still be viral. Do you have any experience in that regard in your center for how you handle those discrepancies?
Yeah, no, I think we're pretty similar with what you just said. I just finished working this morning with Sharice Kwan. We had a great chat about what you were just kind of shared with the group in terms of the use of POCUS. And I know that literature potentially suggests that you find a lot more and you treat a lot more. And then there's other studies that have proven the opposite. So I think the jury's still out on point of care ultrasound in terms of antibiotic stewardship, to be quite frank. But I think, as you said, I mean, we will, if a radiologist interprets it as an infiltrate pneumonia, we'll call the family and obviously, see how the child's doing, but more often we'll start antibiotics. I think there is a group that looked at some of the recommendations about not getting x-rays and felt that that is leading to over-treatment. And again, working in the emerge, how many patients do I see on a daily basis that are sent in, that come in with their fever and cough that's been going on for several days, already on antibiotics for pneumonia. And they clinically, when I'm seeing them, whether it's, based on my assessment or imaging, don't have pneumonia. So I think that is out there, and I know some centers have captured that. And your point about, the lateral, yeah, I mean, if you look at that frontal, you might see what you're seeing behind the heart. So there's, again, a lot of it is, how obsessive do we need to be? Should we be doing like obliques as well with our chest x-rays to look at 4 different views if we believe in doing x-rays? So again, the literature would suggest you'll miss some cases. Are they bacterial? Who knows? It's hard to really know that with certainty. So again, I obviously have this bias from this being a research interest from 20 years ago that Dr. Taheri kindly resurrected and suggested we reach out to this group to see if there was any uptake in terms of looking at that practice pattern. And as I said, I would feel quite comfortable not doing a lateral x-ray, but I am currently still doing 2 views where I practice, to be honest. So.
Great. Well, thank you for that. I see the time, and I also saw as I was speaking, a hand went up and then I think it went down, or so. Certainly we are running out of time, but if someone did have a question, please feel free to send it and we can send it off to our presenters. I want to make sure that that question was answered. So thank you everyone again for joining us for our, late winter, early spring webinar. And we will definitely be planning another webinar, hopefully in the early fall. If we can try to squeeze in 3 this year, that would be great. If you have any suggestions, opportunities, you want to present, some work, please feel free to send us your ideas. We're always open and looking for presenters from throughout the country to share in this work. So thank you again, everyone. Take care.